Hi, everyone. Thank you so much for joining our webinar today. We're going to get started. Just a few things before we get started. If you have a question throughout the presentation, you can go to the right side of your screen where it says questions and enter your question there. All questions will be completely confidential, and Dr. Harfouch will answer them at the last 15 minutes of the presentation. And if you have any comments or any technical issues, please feel free to reach out in the chat and we will be there to help you. Now, with further ado, I'd like to introduce Dr. Omar Harfouch. Dr. Omar Harfouch is a fellow in the infectious diseases at the University of Maryland Medical Center. He is trained in internal medicine at MedStar Health in Baltimore. He also holds a master's in public health from the Johns Hopkins. Sorry, technical difficulties. Okay. Bloomberg School of Public Health, where he focused in epidemiology and LGBT health. He has also worked on numerous research and health policy projects concerning LGBTQ plus health and sexual health in the United States and in Lebanon. Now, Dr. Harfouch, I will let you take it away with the presentation.
All right, thank you so much, Katie, and thank you everybody for joining today. I hope you'll be able to enjoy this presentation. Today, we're going to talk about the sexual health of LGBTQ plus individuals. I'm Omar Harfouch. I am an infectious disease fellow, which means I am a doctor in advanced training in infectious disease. I do use he, his pronouns. I work at the Thrive program, part of the University of Maryland Medical System and School of Medicine, also part of the Institute of Human Virology and the Department of Infectious Disease and the University of Maryland. The Thrive program is located also at the University of Maryland Midtown campus. Okay, so a few disclaimers first. I don't have any financial disclosures. I will say first that I do acknowledge any personal privilege that I may have, and it's important, in my opinion, to talk about this when discussing topics about minority issues. So even though I do consider myself a minority, I acknowledge that I'm a cisgender man and that I will be talking about issues concerning other people who may be underprivileged, and that I hope that we'll be using this privilege to elevate the voices of those communities. All right, so we're going to start off with poll question. One, to get introduced a little bit more to everybody who is on today's call, but also to trial our own poll questioning system. So where is everyone in this webinar joining from? 1, Baltimore City, 2, Baltimore County, 3, other counties in Maryland, or 4 outside of Maryland. Please vote. I know everybody's already put in their zip codes too in the past, but I think it'll help us know who's on here today. Okay, let's see, Katie, is it working okay?
Yes, we'll give people about 10 more seconds and then we'll close the poll.
Great.
Okay.
All right, let's see some of those results. Okay. Okay, I think you must hide the, it's saying you must hide the poll results to enable screen sharing, as those results are not really, I can't see them myself, but.
Sure. So it looks like majority of our attendees are from Baltimore City, and then a lot are actually outside of Maryland as well. Looks like 54% are from Baltimore City and 26% are from outside of Maryland. 14% are from other counties in Maryland, and 6% are from Baltimore County.
Great, okay. All right, we'll move on to the next question then. I think you must hide the poll results so that it could, great. Okay. What age group are you in? 18 through 25, 25 through 45, 45 through 65, or greater than 65? Please vote.
Okay, it looks like 68% are 25 to 45, 24% are ages 45 to 65, and 8% are ages 18 to 24.
All right, great. And so moving on to a next question, which is, what is your sexual orientation? I know we're getting a little more detailed, but 1, lesbian, 2, gay, 3, bisexual, 4, heterosexual, or 5, other. I've included some examples: queer, pansexual, asexual. And while people vote, I want to say, I'm really sorry, I don't usually like to include a big group of populations under other, but the polling system through this platform only allows 5 options. But thank you for voting and for understanding.
All right, so it looks like a couple more people are voting, and I will close the poll. It looks like 46% are heterosexual, 33% are gay, 8% bisexual, 3% lesbian, and 10% other.
All right. Well, please know that also all your answers are confidential and we don't get individual information from this poll. It's all aggregated data. I know that's kind of important to note. All right, and then the last poll question for now is going to be, what is your gender identity? Do you identify as a cisgender woman, a transgender woman, a 3, transgender man, 4, cisgender man, or 5, other? I put gender nonconforming, non-binary, and two-spirit. Again, apologies for combining people in the same category. I'll say that gender nonconforming is also sometimes an umbrella term used to encompass both trans people and other people who don't really abide by certain gender norms or their sex assigned at birth. So you could feel free to include that as an option.
Okay, the results are 58% are cisgender women, 3% are transgender women, 0% are transgender man, 34% cisgender man, and 5% other.
Okay. All right. Well, thanks everyone who's joined and for everyone who's participated in the poll question. Hopefully also that would have given some time for people to join if they're joining a little late. So let me start talking by the goals of today. And really, I know that some of the people participating in the webinar could be a mix of healthcare providers and community members. So let me say first that to people who are from the community, I hope that today you'll get to learn about healthy sexual practices, but also that you'll be aware of resources to seek LGBTQ plus affirming and as well as sex positive care throughout the state of Maryland, but also throughout the country. Know when to seek medical attention and how that would align with your personal goals. And for healthcare providers, I hope that throughout the talk, you'll be able to see some tips on how to engage and listen your patients, particularly when it comes to sexual health, particularly when it comes to LGBTQ plus patients. And the roadmap for today, other than including a lot of photos, as you'll notice, I'm going to start by introducing some terms. Then we're going to talk about healthy sexual practices, as well as moving on to talk about sexual health maintenance and cancer screening, then sexually transmitted infections or STIs, then a special focus on HIV with PrEP and PEP care, as well as HIV care at the end. All right, so let's start by defining some terms. Today we're going to really talk about a sex-positive approach to sexual health. And what that means, it's a judgment-free attitude towards all sexual practices. And this is actually the strategy we adopt at Thrive. We do ask about sexual practices and have zero judgment regardless of what they are. And we'll be addressing that for the sexual and gender minority community. And I will be using the term LGBTQ+ to include everybody in the sexual and gender minority community today. So those two terms will be used interchangeably. And I think that term is kind of the definition is in the term is that it's anyone who's a sexual orientation or gender identity that is a minority. Unfortunately, today we won't have time to talk about other important aspects of LGBTQ plus health, including mental health and cardiovascular health, other aspects of social determinants of health, but know that maybe we'll address some of those as they interact with sexual health. All right, so I like to talk always about this slide by addressing the gender unicorn as an introduction to sexual orientations and gender identities. And this is a great resource from the transstudent.org website that defines what really gender identity and expression, as well as attraction, to be on a spectrum. So in other words, there's no 1, 2, or 3 options, but there's different options that could go on a spectrum from 0 to 100. And so, for example, if we look here towards gender identity, someone could identify as female, male, or other, and can go anywhere on that spectrum. So let's say someone can identify as 90% female and maybe 5% male and 5% other, and that distribution can go differently. Gender identity, again, is how someone identifies when they do look at themselves in the mirror and how they identify from within. Gender expression is really how they express themselves in society. Some of that is really built through certain gender norms that we can see, but you could also see that someone can express themselves as feminine, masculine, or other. And all of that can be also on a spectrum. So for example, today I'm wearing a tie and a button-down shirt, so maybe that would be considered to be a masculine expression, although maybe at other times someone may have a nail polish or lipstick, and that may be considered as a feminine expression. And you could see that someone can really jump between all of these expressions, so there's no true one box that fits all. Sex assigned at birth, right in the middle, is something that's a little complex. It's really at birth, basically, the healthcare providers kind of assign a certain sex for the babies, and that could be either female, male, or other, and intersex. And we won't really talk too much about that. Just realize that it could be potentially a complicated decision, and there's a lot of controversy around that. And then the last two really focus on sexual orientations, and that's physical and emotional attraction. And someone can be both physically attracted to women, men, and other genders, and the same for emotional attraction. Now let's take an example. If someone was assigned male at birth and they identify as their gender identity as predominantly female, then they would potentially identify as a transgender woman. Similarly, someone who is assigned sex at birth, they identify as male, so they are a cisgender man, and they are attracted to other men, then they may identify as well as gay. And as you could see, that's how we can include a large population, and you get a large group of people that would be considered to be sexual and gender minorities. So I hope that kind of explains a little bit some of the terms that we'll talk about and some of the definition, some of the communities we'll be addressing today. And as I move along, certain terms may be unfamiliar, and I'll pause then and there and explain those. Next is, I think, although today the focus is on sexual health, I think it's very important to acknowledge stigma and discrimination, particularly in healthcare, that faces our LGBTQ plus community. And so this discrimination can go anywhere historically up until today, with refusal of care, disengagement in care, people not being really recognized for all their chief complaints, mistreating patients, particularly trans patients within clinics, making certain assumptions about people's sexual orientation or people's partners. The list can go on and on. Particularly now, I think there's a rise in laws and regulations that are proposed throughout this country, different states, that kind of allow or permit for that discrimination in healthcare to be more available. I will say, if you are facing that discrimination in healthcare, recognize that that is definitely not okay, and that if the providers or the clinics that you are seeking are putting that up there, then maybe you should definitely change providers and go to many other places that will definitely have open arms for LGBTQ plus patients. Unfortunately, all that discrimination does lead to higher rates of new HIV diagnosis and lower rates of engagement in care within our communities, as well as higher rates of drug use, mental health distress, and even worse socioeconomic outcomes, which I consider to be a very important aspect of health or social determinants of health. And so that could include higher rates of homelessness and unemployment. Really, all of that stems from what we call in academia the minority stress model. And I won't really go too much into details about that, but realize and recognize that belonging to one minority group, and sometimes you may belong to different minority groups, including racial minority and a sexual minority, then you are facing different forms of discrimination, whether it's from the society, healthcare, in the media, and different aspects that could all affect your health, leading to worse health outcomes. But you're also scared to seek care because of fear of discrimination, and that kind of goes on with a circle of worse and worse health outcomes. All right, so now let's talk about healthy sexual practices, the first topic of today. And really, it's important to stress on that healthy sex, of course, starts with consent. Sexual violence, sexual assault, and rape can affect all communities, including our own LGBTQ+ communities. So if you were a victim of or a survivor of sexual assault, please seek care. It's never late to seek care. There's a lot of trauma-informed care out there. And if you recently underwent any of those unfortunate episodes, then please go and seek care early, hopefully within 72 hours, as I will talk about a little later. And I'll take that opportunity to plug the Mercy Medical Center emergency room that does provide trauma-informed care for victims of sexual violence, with a big focus on HIV and STI prevention, and that collaborates very closely with the University of Maryland and the Thrive program. Now, when it comes to consensual sex, I think the first part would be communication, communication, and communication. Really, communicate with your sexual partner before any sexual practices. Recognize really what are your personal sexual boundaries and what really causes you sexual pleasure, and discuss that in advance. And of course, avoid the use of mind-altering substances and recognize what are your limits with any of those substances, since they could blur your judgment. There's of course no victim shaming or victim blaming in here, but at any point in time, if you are engaging in those substances, at least know, for example, with alcohol, how many drinks could potentially affect your judgment. Have someone who's with you, who is a reliable source to keep an eye. And of course, the people who are going to engage in sex should avoid at all costs engaging with anyone whose judgment may be altered because of substances. All right, now further healthy sexual practices that we'll talk about will include one, that sexual practices really can vary. I know in our own communities, we could have a lot of peer pressure about what sex should look like, with a big focus on penetrative sex, for example, and really know that different things work for different people. So resist that peer pressure. Providers, discuss with your patients that there is no really one way to have sex, and that different things really could work for different people. Talking about barrier protection and lubricant are two important things that go hand in hand. Barrier protection, of course, with non-monogamous partners or with in the setting of different partners. And those come in different shapes, forms, and sizes. Condoms and dental dams most commonly. Condoms are available in female and male condoms, and female condoms are able to be used with neovaginas as well. That is a new vagina that is constructed for trans women. Dental dams are used mostly during oral sex, and they could be either a condom that is cut in the middle as a form of barrier protection during oral sex. Lubricant is very important when it comes either with condom use or in all sexual practices, really. It does provide, particularly in areas where there might not be natural secretions of fluids that will facilitate penetration. If you are practicing anal sex, do watch out for your anal health. We could do a whole presentation about anal health, but I think a few points to take home on would be one, watching out for anal fissures. That is a tear that can happen right around the skin of the anus. And that is the biggest risk factor for that is really anal sex without the use of lubricant. It could cause pain, and so the best treatment is really prevention by using lubricant during anal sex. And in case you are having some of that pain, to definitely seek a provider to be able to assist you. The other part would be also talking about douching practices. That is the practice of kind of pushing water within the rectal vault, so within the rectum or the anus before sex. And really, the two things to watch out there for are, one, again, the use of lubricant during whatever procedure is being used for douching, and two, to watch out for excessive douching that could increase your risk for sexually transmitted infections. And I think this is an important point, and I put it here in healthy sexual practices, as it will be a common theme throughout, is to have a healthcare provider that you are comfortable in discussing your sexual practices with. If you are a healthcare provider, ask your patients about their sexual practices, provide cues throughout your clinic that will make LGBTQ+ patients feel comfortable, whether it's posters or pins, and ask them even about their pronouns. I think that's critically important for everybody to feel that they are welcomed in your own clinic. All right. Although I will discuss the sexual health of trans and gender nonconforming individuals throughout the talk, I will say that in this slide is going to focus on some of the issues that pertain particularly to this population. One, that not everyone who is trans or gender nonconforming will seek or has to seek gender affirming hormones or surgery. And that kind of applies to both. On one side, to talk to, if you are trans or gender nonconforming, please know that there is no obligation at all to succumb, again, to some peer pressures sometimes, or also to healthcare pressure to say that you need hormones or you need surgery. So it's okay if that's not the right thing for you or not the right thing for you right now. And you could, with the help of your provider, discuss what your goals would be, your gender affirming goals. Similar for providers, kind of acknowledge that that discussion is important and doesn't always necessarily have to lead to either prescription of hormones or to surgery. If seeking surgery, one, know that for all gender affirming surgeries, with the vaginoplasty, phalloplasty, and metoidoplasty. So vaginoplasty is formation of a new vagina in people who identify as trans women. Again, that's people who are assigned male at birth and who currently identify as women. And then phalloplasty or metoidoplasty is the formation of a new penis, basically, in trans men. And just recognize that it may be months or weeks before being able to have penetrative sex, and talk to your surgeons about that in advance. I know sometimes healthcare providers may push sexual health to be lower on their list of priorities when talking about a lot of things that they got to talk about around surgery. So definitely ask what the expectations would be. And in case of vaginoplasty, again, the formation of a new vagina, lubricant is still needed during sexual intercourse. The reason being, the tissue that is used to form the neovagina does not really secrete fluids to facilitate penetration. So just realize that you'll still need lube. All right, another poll question. I hope that people 24 minutes in are still awake and ready to answer. So out of the following individuals, who should really consider anal cancer screening? A cisgender man who has sex with other men. 2, an HIV positive transgender man who has a history of anal warts. 3, a cisgender bisexual woman who practices anal sex with multiple partners. Or 4, all of the above. All right, Katie, hopefully there are still people who are answering. People are excited about the talk and are trying to make their best guess. Don't worry, no one's getting graded today. All right, what do those results look like?
All right, can you see the screen?
I can't see the
It
results.
looks like we got 100% said all of the above.
All right. Yeah. I mean, that is a great guess. And that is actually the correct question in this case. And so let's talk about sexual health maintenance and cancer screening. You know, to talk about sexual health, we got to make sure organs involved in sexual health are maintained to be cancer-free. And so some practices and how that focuses on LGBTQ plus communities. One, breast cancer screening really should be done with anyone with breast tissue. So a few examples: a trans woman who's been on gender affirming hormones for a certain number of years and who is older than 50 will need to seek breast cancer screening with mammograms or other forms. Similarly, a trans man who's had top surgery, which is the removal of breast tissue, may still have some persistent breast tissue and may still need to seek breast cancer screening. So discuss that with your providers, particularly providers who are aware of trans practices of primary care towards trans people. Cervical cancer screening is needed in anyone who has a cervix. And so trans men who have had, who still have a cervix do need that screening done. And a big plug here for cisgender women, so women who are assigned female at birth and who identify as women, who are either same gender loving, lesbian, or bisexual. Please know that you are at risk for cervical cancer, and that's because epidemiologically we know that there's lower rates of screening and higher rates of cancer in this population, mostly because it's discovered a little later. So so it's still important to seek that screening, those screening practices. We have less clear guidelines about anal cancer screening. The population that definitely will benefit from this is going to be anybody who is HIV positive and who practices anal sex and who has had a history of anal warts. The age may vary. Some people suggest to start at age 30, and particularly this is most been studied in cisgender men who have sex with other men. However, we think that anybody who has anal sex may be at risk. Similarly, in the HIV negative communities, we don't have as much data, but we think that maybe if you've had a history of anal warts, that is again some warts that are formed around the anus, or if you've had a history of cervical cancer, so that means you've been exposed to HPV, it might be beneficial beyond age 50 to get screened for anal cancer. The way that is done is really through a very small Q-tip, what we call anal paps, quote unquote. It's an insertion of a very small Q-tip that tries to detect cells that may be cancerous. And so how does that also conversation come in with sexual health practices? Also to talk about HPV. HPV is a virus that is transmitted sexually, and it's transmitted by skin-to-skin contact, which makes it very easily transmittable and very commonly available. Basically, it's very common in anyone who who is sexually active. Now, there are certain types of HPV that could cause cancers, particularly cervical cancer, anal cancer, we've talked about, throat cancer, and penile cancer, and those we don't really have screening forms for. Although if you do have symptoms towards that, you should seek care. But the good news is that we do have vaccines that are very effective, and so anyone up until the age of 26, and even maybe to age of 45 in some cases, can still benefit from HPV vaccines. So talk to your providers if you are eligible, and most importantly, if your insurances will cover it, know that HPV vaccines are safe and they can protect you from further cancer. All right, another poll question. So among the following symptoms, which should make you seek attention to get screened for a sexually transmitted infection or STI? 1, rectal bleeding. 2, discharge from any genital organ. 3, burning on urination. 4, rectal pain. Or 5, all of the above. So this is going to introduce our next topic of STIs. Hopefully people are midway through their lunch and are still able to answer some of these questions. Right, how are we doing? What's it look like?
It looks like 100% of people said all of the above. and
Okay.
72% voted. So it's great.
All right. That's good. Yeah. All right. So people who started are still here. That's good. Some people don't, again, you don't have to answer these questions, but we do appreciate there's no right or wrong answer. There's no punishment for any wrong answer. And the correct answer here is actually all of the above. So we'll talk about STIs. And I'm going to start by talking really about this big unashamed banner. Since stigma around STIs is very prevalent, and particularly in our own communities. And so truly anyone who has sex is at risk of contracting an STI. Barrier protection, so condoms again that we've talked about earlier, do protect from a lot of STIs, but that's not always the case. Some STIs can be transmitted through contact, so skin on skin. We've talked about HPV. Others that come to mind include herpes and syphilis. But also, sometimes barrier protection may not be 100% effective in protecting from STIs. And so that's why the key part here is to really get screened, get tested. And what we do want to get tested is all the sites that are used during sex. So oral or pharyngeal swabs are available to test, as well as rectal or anal swabs. And then urinary tests are available. And finally, vaginal swabs are available for tests. So that's, again, another important point to discuss your sexual practices with your provider so that they could acknowledge where and what to screen. Unfortunately, we don't have clear guidance on testings, for example, of neovagina, although some people think that urinary testing would be the equivalent in that case. If you are a provider, please know that in case you are not screening all sites that are used during sex, you're probably missing a lot of gonorrhea and chlamydia. So ask your patients about their sexual practices. Partners, so if you do test positive for an STI, please notify your sexual partners so that they get tested and potentially treated. And if you do test positive, you'll also need to seek treatment. And after treatment, you'll need to abstain from sex for 7 days. Believe me, that's the only time you'll hear me say the word abstain throughout this presentation. But that's really because the major concern is reinfection. And so to be on the cautious side, avoiding any sexual practices for 7 days. Stop stigma, finally, as a big point when talking about STIs. So certain terms that we might use in communities, I've heard the word clean frequently. That is really a very stigmatizing term that can cause people who test positive for STIs to feel shameful, to avoid notifying any partners, and to even sometimes others avoid getting tested. So really, all of these terms can be very harmful, so we should start reflecting within our own communities on that. So what are some symptoms that should make you think about an STI? So most people are asymptomatic, and I can't stress that enough. That's where the importance again comes of getting screened. If you do have multiple partners, you should at least get tested once every 3 months and get screened again at all the sites that you're using for sex. Other symptoms should cause you to go seek care earlier, and that can include discharge from genital organs, rectal pain, rectal bleeding, pain on urination or testicular pain, and a painful rash or ulcers. Now, sometimes STIs can also present with different strange symptoms that we might not always commonly see towards whether it's rectally or towards genital organs. So do discuss your sexual practices with your providers so that they could have that also on their differential and know what to test. Providers also take a very comprehensive sexual history to all your patients. And then another STI that we don't talk much about when addressing STIs is hepatitis. Although it is definitely at risk, there is a high risk of acquiring it sexually, and that's all 3 hepatitises, A, B, and C. Mostly seen in MSM, but no reason to also think that it won't be acquired through anal sex in general. And so hepatitis A and B, there are vaccines for that are very effective. So get tested, see if you're already immune, and if you're not, you could get the vaccines for those. For hepatitis C, we don't have vaccines, but we do have very good treatment. So get screened at least once per your lifetime to see if you carry hepatitis C, and you may get treatment and cured. All of these viruses can cause different inflammation of your liver, and if detected earlier and when you seek treatment earlier, you'll be able to avoid leading to worse liver outcomes. All right, enough talks about STIs. Let's move to talking about HIV with this next poll question. How often should someone who engages in penetrative sex, and what I mean about this is, in this case, a penis to what we're going to call a front hole or a vagina with multiple partners, get screened for HIV? So I use the term front hole and vagina here differently, since some people may refer to that organ as a front hole, particularly in gender nonconforming communities. So is it get tested once a year for HIV, twice a year, every 3 months, or they do not need to get tested since they are not at risk for HIV? As we move along, some of the questions are getting harder. But again, that's just to see what people think, what people know. You could take a lucky guess, and hopefully that will also help you keep engaged. All right, Katie, how's it looking?
All right. Looks like majority of people said every 3 months.
Okay.
67%.
Well, all right. Okay, that's good. So that is a good guess, and that is the correct answer. So HIV testing, I like this big ad that says, I know my story, I know my status. Do you? I think it's so important for everybody to get at least tested once per life, regardless of your sexual practices. Get tested at least yearly for anyone who is sexually active, and truly every 3 months if you do have multiple partners, particularly if those sexual practices do put you at risk for acquiring HIV. And so you might have heard in the past about this window period. It's this time between when you are exposed to the virus and when a test will turn out to be positive. And really, that period has become shorter and shorter with newer tests. However, if you have been exposed to HIV and are experiencing symptoms like a cough, a sore throat, a fever, do tell that to your provider and tell them that you think you might have been exposed to HIV so that they know which different tests to order. All right, a follow-up question, and this one is not with a poll. We could not put in all those lengthy answers into the poll system, but out of the following people, who does qualify for PrEP? Since we're going to start talking about pre-exposure prophylaxis. A trans woman who is a sex worker and HIV negative. 2, a gender non-conforming person who injects drugs and whose HIV status is unknown. 3, a cisgender bisexual man who engages in both penetrative and insertive sex and who recently tested positive for gonorrhea. Or 4, an HIV positive cisgender woman who is in an open relationship with her husband. So while people do take a mental photo of this question and try to answer it, I'm just going to drink some water. Okay, good. So the correct answer here is actually an HIV positive cisgender woman who is in an open relationship with her husband, answer 4. And that is because this person's already HIV positive, so they should not really be on prevention or pre-exposure prophylaxis, which in the case of HIV would be considered to be an incomplete treatment. So let's talk about PrEP and PEP. What is PrEP? It is one pill once a day that is proven to prevent HIV transmission. And I do say that sentence with also a lot of caveats. First up, the one pill. Although this is the most studied form of PrEP is 2-pill form, there are potential new studies further down the line that are investigating the use of an injectable injections to be used as PrEP. More to come maybe about that later. And then once a day, and most of the studies were done with people who are taking the pill every day. However, there are certain studies that were done on event-driven PrEP or PrEP as needed. And that's basically the model where, in case someone thinks they're going to have heightened exposure to HIV, let's say multiple partners in a couple of days or 1 week during every couple of months. They will start taking PrEP a couple of days before, during that period of exposure, and a couple of days after. And I do say that is not for everybody because it definitely has not been studied very well in trans women and not even that well with cisgender women. So the best population where it's been studied is really cisgender men who have sex with men. Adherence is very important. So as with any medicine, if you don't take it, it doesn't work. Same with PrEP. If you don't really take that pill, you will not be protected from HIV. And very few interactions, the PrEP medication has very few interactions with other medicines. Particularly, it is safe with gender-affirming hormones for trans women, so estrogen and androgen testosterone blockers. Know that that is there's no interaction. You should, and similarly, actually for testosterone in trans men, although there are no detailed studies that have looked into this, we know by extrapolation, maybe from HIV studies, that there shouldn't be any concerns for interaction. Nonetheless, anybody who goes on PrEP should monitor their hormone levels as they do regularly with their gender-affirming provider. So this is particularly in the transgender community. All right, is PrEP for you? So really, PrEP is for people who are HIV negative, who are monogamous. So there's different categories of people who would really start to qualify. Either someone who's monogamous and has an HIV positive partner, and so to prevent the risk of HIV transmission in that case. Or if they do have multiple partners and engage in sexual practices that are at risk of transmitting HIV. So that will be penetrative sex, and that includes penis in, again, a front hole or vagina or an anus. So part of our community here would be cisgender women who have sex with only other women. That population is not at risk, so not really qualifies for PrEP. Now, the other part would be injection of drugs, where PrEP has also been proven to prevent transmission of HIV in people who share needles. So what do I have to do if I'm interested in PrEP? One, connect with a PrEP provider. There are many throughout the city. I know we'll plug here the Jacques initiative with a PrEP linkage to care to find out which provider suits you the best, but also to know and discuss what best PrEP practices would be for you. And then once you start PrEP, you'll need to follow up once every 3 months to, one, get screened for HIV and STIs, as we've talked about earlier, but also to check for your kidney function. And that is because, just like any other medication, a lot of the medicines we use, PrEP is secreted through the kidneys. So we'd like to monitor the kidney function for the first, especially earlier on. And of course, take your PrEP consistently as prescribed. A word about PEP, or post-exposure prophylaxis. It does involve taking anti-HIV drugs. That's very soon after a possible exposure to HIV. That's to prevent HIV acquisition. So if you have engaged in any activity with high risk of transmitting HIV, particularly whether this has been a sexual intercourse without the use of condoms, or whether it's any kind the use of condoms that might not have worked too well, and you are not on PrEP, then you need to go to an emergency room, an urgent care, an HIV clinic, or call your provider within 72 hours. You have that window of from exposure to prevent HIV acquisition through post-exposure prophylaxis. Do not give up. There are a lot of resources, again, plugging the Jacques initiative, that you'll have those resources with you sent by email and towards the presentation to call and get connected with PEP. And so talking again about victims of sexual violence in this case, although it's obviously very hard to deal with this trauma, it's very important to try and seek care within those 72 hours to potentially get on post-exposure prophylaxis, especially if the violator is the violator's HIV status is unknown. All right, last poll question as we get close towards the end. I tested positive for HIV. Now what do I do? So number one, I won't need to see a provider for a couple of years, since what I've heard is my CD4 is probably fine. 2, I can never have sex again. 3, I have a very few more years to live. HIV is a death sentence. Or 4, I should seek care as soon as possible and start treatment. Please vote.
Okay, give you a few more seconds to answer.
Thank you.
Okay.
All right, Katie, how are we doing?
Looks like 100% of our voters said I should seek care as soon as possible and start treatment.
All right, great. Thank you. Well, I'm glad that everybody is still also participating. And a few words about HIV care. So one, let's talk about HIV. And before we talk about HIV care altogether, I think it's important to indicate that HIV is on the rise in our communities, particularly in Black trans women, in other trans women of color, and in Black, gay, and bisexual men. And while it's definitely easy to point blame, that's not the case of what we're doing here. I think a big part that we need to acknowledge is the history of unethical practices that have been performed against and continue to be performed within health when it comes to structural racism as well in our Black communities. Unethical practices that come, for example, to mind are the Tuskegee experiments where people were injected with syphilis. In our own LGBTQ plus communities, also, we do feel marginalized sometimes within healthcare and may feel resistant to trust the healthcare system. That does reflect on HIV, where we do have very effective methods to prevent HIV through PrEP, as I talked earlier. And we do have great treatments for HIV through people who get connected to care after getting tested. But people may be wary of getting to all these three. And I hope that while acknowledging all the harmful past that we've been through, also to recognize that our communities need to heal, and the best option is to protect our own health. So seek testing, seek PrEP if you're HIV negative, and seek care if you're HIV positive. And HIV care has really changed through the times from the days of ACT UP. 40 years after the first person tested positive for HIV, our medical approach has really changed. While earlier there wasn't enough research done on HIV, people were dying very shortly after being diagnosed. And of course, the treatments that were available had a lot of side effects. Today, we have one pill once a day as a treatment for HIV. It will lead to get the virus undetectable, which means the virus will be under controlled, suppressed by these medicines. And that means that it'll remain in the body, although it won't be causing any damage to any organs. Additionally, it'll cause early start. The earlier you start that medicines after you are test positive, the better. That's what the studies have shown us, that people who will start earlier will have better health outcomes. However, adherence to the medicine is very important to reaching that status. So before you start the medication, you got to be ready to commit to take that one pill once a day. And of course, it's not a commitment you're in alone. At Thrive, and I know at other HIV clinics, there's always a holistic approach where you have an army of people who will help you adhere to your medicine, whether it's social workers, support groups, your own providers, nurses, and a lot of people throughout the healthcare team. And so why is being undetectable so important? If you become undetectable, the life expectancy of anyone living with HIV approaches that of anyone who's HIV negative. HIV is no longer at all a death sentence when treated. Also, undetectable, and hear me very well, if you do reach that status, your risk of transmitting the virus is 0. So undetectable equals untransmittable, U equals U has been proven in multiple studies. Undetectable also leads to, on one part, a better immune system, protection from other infections. Recently with COVID, there was a lot of concerns about lower immune systems, but also it will lower, if you are undetectable, you'll have lower risk of having heart disease, strokes, kidney disease, depression, and cancer. Really, the virus acts on multiple organs in your body, and getting it to undetectable status is very helpful. So let me conclude by talking about the services we offer at the Thrive and the JAX initiative. The Thrive is located, so again, the Thrive program is located at Midtown campus. We offer wraparound services around HIV care. That includes primary and specialty care, hepatitis C treatment, gender-affirming care for those seeking gender affirmation, mental health care, opioid use disorder care for anybody who struggles with addiction, nutritionists and pharmacists, as well as cancer screening, a lot of which we've talked about throughout this talk. We also have an army, really, of social workers who are very passionate about their jobs, into connecting with employment counselors, housing coordinators, mental health counselors, making sure that you really receive the best care possible. The JACS initiative offers a community supporting health system and engages communities really through both home and community-based case management, where we can visit at home to provide some of the care if it's difficult for you to get to the clinics. Treatment adherence pharmacies, as I talked, adherence is very important. So a lot of work around helping you with this adherence. There's also HIV and hepatitis C testing, and then HIV prevention, both through PrEP and PEP and linkage to care. Sister programs, the STAR track, of course, available through the University of Maryland, as well as an adolescent health program that offers HIV and STI testing, treatment, and prevention. If you are an adolescent, if you know of any adolescents who would benefit, definitely take note. Other resources throughout the state, other clinics that are listed here. I'd make sure to also plug GLAMA, the GLMA, Health Professionals Advancing LGBTQ Equality. It's a national organization that also enlists providers, has a provider directory where you could find your LGBTQ plus affirming provider closest to you. More to come, hopefully very soon, a gender affirming care clinic at the University of Maryland Medical System. All right, and with that I conclude with some take-home points. Know your HIV status, get tested for STIs and HIV. If you're living with HIV, get engaged in care, get screened for anal, cervical, and breast cancer screening as appropriate. If you're a healthcare provider, discuss with your patients their sexual orientation, their gender identity, their sexual practices. Have signs throughout your clinic to show that you are LGBTQ plus affirming, celebrate events like Pride, be attentive to the needs of your patients, and be ready to learn from them. All right, although it would have been great, unfortunately we can't do the Pride Parade this year. Maybe we would have avoided the cicadas, but I'm gonna put the slide up with the addresses for JACS Thrive and the numbers. You'll be getting those as well through the pamphlet. And a little late on finishing, but hopefully we'll be having some time for questions. How are we doing on the question side, Katie?
Yes, I know that we have about 7 minutes, so I am going to share my screen. We have lots of questions that came in. If Dr. Harfouch does not get to your question, we will follow up in an email after this webinar with the response to your answer, to your question.
Right.
The first question that we received, let me just see if I can really quickly.
Please know, of course, that all your questions are confidential, so
yes.
We won't have identified.
Can you see my screen?
Yeah, I can.
Okay. This is the first question. Is there any information about sexual health in the LGBTQ plus community that you find many people don't know or always have questions about?
Yeah, there's a lot of things, I think. On one part, a lot of people don't know that they do definitely need to get screened at all 3 sites that they're practicing sex with. So even within the healthcare facilities, a lot of people only test urine for certain STIs like chlamydia and gonorrhea. So I think that's a big one. I think there's still some PrEP, although PrEP uptake and the dissemination of PrEP has been more common. I think a lot of people still don't know if they would benefit from it. So people recognizing they're at risk and seeking that care. And then at the same time, some providers may miss that some people that they just tested positive for an STI, for example, to qualify for PrEP. It's very important to intervene within that window. So I think those are some of the 2 points. Another point that comes to mind is definitely anal cancer screening in certain populations that qualify. Again, some of those people may be HIV negative, older than 50, if they have a history of anal warts or cervical cancer, and in HIV positive people, maybe up until the age of 30 even, to start anal cancer screening. Yeah, I hope that answers.
Great, thank you. Next question. How would I find a physician in Baltimore who is gay?
Excellent question. So I don't know about if there's any resources that really list people's or providers' sexual orientation and gender identity, although the GLMA website, glma.org, that also will be disseminated to everybody through the emails afterwards, will give you a directory of providers who are near you and who are LGBTQ plus affirming, which I think is a very important part. I would tell you easily that at Thrive, where we do offer HIV care and HIV prevention care, we do have a lot of our providers, of course, are LGBTQ plus affirming. And the JACS initiative is actually a final other great resource with a linkage to care that can be provided, whether it's related to HIV PrEP or even Hep C treatment for providers throughout the city.
Great, and just like Dr. Harfouch said, after this presentation, there will be the presentation will be recorded, as well as that link to be able to find a provider. Next question, what are sexual health options besides the LGBTQ plus people, besides PrEP, condoms, and routine STI testing?
Yeah, so within sexual health practices, really getting screened if you do have multiple partners. Unfortunately, there are certain studies maybe done on STI PrEP that's still not really validated. So getting tested and getting tested frequently, being closely connected with your healthcare provider about about your sexual health in general, I think that'll be important. Other aspects of sexual health, maybe that we didn't really get to touch base on, I think again, anal cancer screening altogether, that is part of sexual health. So I'm not sure if maybe this question is also interfering about if someone does have multiple partners, what to watch out for, but definitely they could discuss what options really work for them, since a lot of this could also be individualized decisions. So you should have an affirming provider who's happy to discuss your sexual practices with.
Great, thank you. Next question. What are some sexual health risks and considerations faced by bisexual individuals that doctors and patients should be aware of?
Yeah, I mean, I think there's unfortunately a lot of bisexual erasure in our own communities. And so one, recognizing that, bisexual people are people who are attracted to men and women, but doesn't necessarily mean that they're always practicing sex with all with both men and women. At the same time, it's kind of going to go back to a lot of the concepts we talked about, which are, sometimes some people may think that because you're bisexual, you don't belong in certain boxes that maybe they would put you in when it comes to, for example, HIV testing. But bisexual individuals are at risk of acquiring HIV, so they do need to get tested, right? As opposed to, we talked about a group of cisgender lesbian women who only engage in sex with other women. That group is not really at risk for HIV. So again, depending on the sexual practices, that's where the aspects of sexual health would come in. And of course, a lot of what we've talked about, whether it's about consent and sexual violence and all of that would also apply for bisexual individuals. Yeah, so I mean, I guess it's going to circle back to that same conclusion that you need to be comfortable talking about your sexual practices, your sexual attraction, and your attractions in general with your provider, and so that they could kind of individualize that care to you.
Great, and I think we have time for one last question.
All right, let's try it.
What percentage of MSM are not on PrEP, and what is the most common reason for refusing to begin taking PrEP?
Yeah, so unfortunately, might not have the numbers off the top of my head. Unfortunately, PrEP rollout has disproportionately affected MSM of color, so Black and Latinx MSM particularly, where the uptake of PrEP hasn't been as high. And I think part of it is definitely related to what we've talked about earlier, with issues of mistrust with healthcare due to prior, health racism in healthcare. And so there's also that fear that PrEP may cause side effects. Other than MSM groups, there's also trans women where a major concern earlier on was about interactions between PrEP and gender affirming hormones. And so that we do have more information about now, knowing that there's no interactions between those two. When it comes to safety, and I'll say this both about PrEP, but also about all HIV medicines for anybody living with HIV, the safety profile of the drugs has really improved with time. Again, aside from monitoring for creatinine once every 3 months, and there's certain other personalized groups where maybe we'd want to also watch out for bone health if you do have some predisposing factors. But aside from monitoring that kidney function, and as we monitor it closely, there's the risk of really getting into a major side effect is none. So watching people very closely can hopefully help people get more engaged in PrEP and not be worried too much about side effects. And yeah, I mean, finally, it's just really discussing if PrEP is right for you, and knowing what that entails. And I think that's it's a great way also to engage people in care, to get screened more frequently, since that had been a challenge in the past, also to get tested both for STIs and HIV. All right, I think that's our time.
Yes. Well, thank you so much, Dr. Harfouch, for being here, and thank you all for attending today. Just if Dr. Harfouch did not get to your question, we will be following up with the answer, and you all will be getting an email of this recording of this presentation. We really hope you enjoyed it as much as I did. Thank you so much.
Thank you, everyone. I hope you benefited from the talk, and happy Pride Month. Go and enjoy the rest of the Pride celebrations of this week. Enjoy it safely. And yeah, I'll be happy to answer all the questions offline. Have a great day.